see, I'm not going to necessarily post them, but you'll see, you may see, I don't know if you're doing it on your phone, but I see people like chatting on the side and stuff. So don't let it distract you. So
Okay.
I know. And then I need to mute this. All right. Hopefully we are. All right. It looks like we are starting up. Okay. Here we are. We are on. Welcome to the quarantine edition of the Jack Mitchell podcast. We, like everyone else, are switching over to the Zoom-like situation. And so I want everyone to welcome in my guest today. And hopefully we're okay with the sound here. If there's any feedback or anything, if you have to plug in headphones or anything, we can do that too. But Dr. Anthony Marsh, Dr. Andrew Sauer are joining me right now. Dr. Marsh is in New Orleans right now. Dr. Sauer in the Kansas City area. I picked these guys because they are both guys with local roots from the Lincoln, just outside Lincoln area. And now they're on the front lines of this thing. And I think getting a picture of what that looks like is really important right now. And so I'm excited to do that. So let's get a little introduction for both of you. Dr. Marsh, tell us a little bit about yourself.
Yes, hi, Jack. So I grew up in Lincoln, went to Northeast High School, graduated in 2000. I ended up moving to Minnesota for college and then found myself back in Omaha for med school at University of Nebraska Medical Center. I did my internal medicine training at Tulane and continue on as one of their associate program directors in the internal medicine department. My day job is primary care and administrative work at one of our local hospitals. And that's kind of that's the quick and dirty.
And tell us how your day job, your regular 9 to 5, say 4 months ago, is different than what it is now.
Yes. So we have a new normal here. Our rates, 3 weeks ago, I think we had our first case on Sunday admitted at one of our hospitals, and now we're over 3,000. So on an inpatient side, the hospitals, particularly the ICUs, have filled up really quickly. I think that our 3 major facilities here, we're sitting at over 80% of our inpatient admissions are COVID positive patients. So we are working around the clock to kind of restructure how our ward system or our inpatient or ICU level rooms are structured so that we can handle the increasing volume. We're finding that with this disease, people can go 7, 10, 14 days with pretty mild symptoms and then really quickly deteriorate. From the outpatient side, we're really trying to focus on telehealth, convincing our patients that they don't have to come in and see us, that we can reach out to them, and we're doing a lot of this kind of appointments with them.
Dr. Sauer, give us a little bit about your background and maybe how, where you started, where you're at now, and how that has changed or will change.
Yeah, so I grew up in Nebraska as well, a bunch of small towns. I graduated from Milford High School and went to college at Nebraska. I met my now wife at the time while we were in college there. Then we left and moved around a bunch. So did some time in upstate New York for med school, trained in Boston, and then finished up training in Chicago in cardiology and heart failure, heart transplant. And then shortly after training, I was on faculty there at Northwestern. We were recruited to come down to Kansas City to reboot our heart transplant program at the University of Kansas Health System. So my main job here is to focus on growing the program to serve patients with heart failure, which, as we've seen on the news, is the most vulnerable population to potentially suffer from COVID-19. Cardiovascular disease patients, and most notably the heart failure population, are very vulnerable. And so my job is to take care of those patients, including patients with heart transplant and mechanical devices like LVAD. No matter how this virus goes, we've got to find a way to take care of these patients. I do attend in the ICU, and last week I was on our COVID units. Kansas City, we have been able to benefit from being more prepared, I think, as watching our colleagues in New York and Seattle, Washington, and California and Boston. our networks are wide, and we're all pretty plugged in on Twitter and other social media platforms so that we can keep up with what's going on. And I think we've been very aggressive in Kansas City at social distancing and shutting down traffic and, really shutting down business operations to minimize community spread. And we've had the same challenges as everyone else. We don't have great testing. We don't have a stockpile of PPEs or personal protective equipment. Our ICU has 20 something patients with COVID right now. And our state is, again, growing, but farther behind New Orleans and New York. But I think the most important message for the public is it doesn't really matter what city you're in. I mean, how can we not learn the lessons that we've seen in China, in Wuhan, in Italy, in Europe, now in New York? This virus just goes everywhere, and it will come to every neighborhood across the country. It already has. And if we don't find ways to buy the frontline providers time by practicing social distancing and giving this time to really let the surge happen, more unnecessary deaths will continue.
Dr. Marsh, what would you say you've learned about the COVID-19 virus since you've started seeing it and been seeing it in person more often and treating it?
I think that I'll kind of echo what Andrew was saying, that a lot of us underestimated just how much there was community spread going on as early as February. And I think that a place like New Orleans didn't catch it as soon as other places like Kansas City and hopefully like Omaha and Lincoln will. And so we're dealing with the aftermath of people who have now been infected 2 weeks ago. And the numbers that are coming into the hospital are a result of our behavior from several weeks ago. We don't get to make that time up. But I think that if we can get over some of our arrogance and really follow the rules of 6 feet, doing as much social isolation, staying at home, don't go out, wash your hands, don't touch your face, I think we can make a dent. This is a new normal, and this is a numbers game. So if you have 20% of your population infected with this virus and 5 to 10% of those require some sort of hospitalization, 1% ICU level care, you think about a town of 250,000, just the sheer number of ICU beds that are required. We really need to spread that out and not have it all happen in May, frankly.
Dr. Marsh, and by the way, just to reintroduce, I know we're getting new people in here as I'm getting links up on Twitter and everywhere. And some people will be watching this on a replay, and we'll get a lot more views there too. Talking with Dr. Marsh, he's in the middle, graduate from Lincoln Northeast in 2000, and now working in New Orleans. Dr. Sauer, a Milford, Nebraska graduate and a Nebraska kid originally, and he's in the Kansas City area. Dr. Marsh, we heard Dr. Sauer talk a little bit about what the conditions are right now, what the preparations are, how many people are there. It hasn't completely hit. Give me a real world sense of what it's like behind the doors of the hospital that you're working in this week.
I think I take my hats off to the frontline providers, those in the ICU. Their census are full, and we're constantly recruiting providers both on from a hospitalist side to manage patients in the ICU and from the outpatient side to manage hospital admitted patients. I think the volume has just exploded. We already have at the convention center downtown, they are set up to create an additional number of beds to keep up with the growing census. It's so fluid. I don't want to give you specific numbers, but we are finding that I think yesterday we had 4,000 positive cases. 30% of the people are touching the hospital and being readmitted before their test even comes back. And so I know that talking with my colleagues, they've never experienced anything quite like this before.
How are you set up in terms of equipment? We've heard so much in the national news about PPE, about gowns, about that kind of stuff. What's the situation there for you?
Yes, it's been up and down. I think that we had to make some very thoughtful decisions about how to utilize our PPE effectively. A lot of that came down to training people and making sure that they know how to don and doff the equipment safely. Also to train people on who should be getting the full gear and who would be most benefited from a mask or an N95. And I think there's a tendency that everybody wants to run and get their own personal protective equipment. But frankly, we should be keeping that for those who are really facing the aerosolized droplets, whether someone's actively coughing or they're doing the actual testing. And I think once we develop the process, we've been able to kind of stay ahead of that. And hats off to the hospital administrators and our governor for that kind of work.
Mm-hmm. Dr. Sauer, how well do you feel like your people are prepared in terms of what they have, even if you haven't really hit the crest of this?
And again, I think because we've had more time to watch New York and Seattle and San Francisco and now New Orleans, we're more prepared, we believe. We still have the same challenges. Our supply chain, for example, has to take very regular stock of supplies of all forms of PPE. But we're being very resourceful. For example, last week we had community leaders reach out to say, how can we organize to donate the masks that the community has? So as we all know, the N95 masks are used in construction and don't necessarily stockpile just in healthcare. And so we had a fundraiser or I should say a resource awareness to donate, people who had surgical masks and N95 masks. And I don't know the exact tally on how that came about, but that was organized last week. And, our supply chain folks tell us that we are okay for now. But I think if we have a surge like has been seen other places, which we're working very hard to avoid through community outreach on social distancing, I think we are going to be just like everyone else, going to be concerning for how we run out of supplies. We're now wearing masks around the hospital. So when we're not seeing COVID patients, everybody wears a mask to make sure that if there's asymptomatic spread or minimally symptomatic spread that we don't know about, then we all have masks to help protect our patients and our staff. When we walk into the hospital, we are screened for temperature elevation. We have stripped out many of the visits in clinic. What I'm doing today is I'm working in my office doing Zoom meeting encounters with patients with heart failure and heart disease to minimize the exposure between me and them, and also to minimize me being exposed, me exposing my team to me, because I could be carrying the virus from all my time in the COVID units last week, and I wouldn't have symptoms yet because it's only a couple days into the week. So I'm actually in isolation for the next few days, working remotely for my patients.
Have either of you gotten tested just to make sure at any point?
I've not been tested. So the problem with testing is that we generally can't test unless patients are sick. So the community can't get a test right now. Healthcare workers can be tested, but not until particular criteria are met. So having no symptoms, having no fever, I'm not going to be tested. But we all know that, from the China data, from the Italy data, from many cohorts, that a significant amount of the community spread out there is driven by patients with no symptoms. And notably, the South Korean cohort showed that it was the 20-year-olds and the 30-year-olds that were most infected as a cohort. So all the parties on the beach, the stuff you're seeing out of some of the cities, lack of social distancing, even gathering right outside the Navy ship Comfort, just yesterday, you saw all those people, that's how it's spreading. I mean, and all that does, is make our jobs harder. It's not just the COVID deaths. And this is another thing that doesn't get discussed. So my patients with heart transplant, with VAD, who need heart transplant or LVAD, mechanical devices, many of these patients waiting for heart transplant or waiting for surgery, they have a likelihood of dying in the next year that's over 50%. And so we are intentionally delaying things, delaying transplant, delaying these surgeries to try to avoid having them have surgery in the midst of a ICU that is being overwhelmed by COVID. And those deaths don't get added to the tally of COVID deaths, but people waiting for surgery that really isn't elective, but we're delaying it arbitrarily to wait for COVID, those people die too. Just last week, we had a patient come in with a heart attack who we thought might have COVID. And we had to use an old-fashioned way of treating that, something called lytics, which are clot busters, which is what we did before we had stents. We ended up doing that because we didn't know how many people were going to be exposed, and it worked for a couple hours, and the patient needed a stent anyway. Now that patient is doing very well. He's going to have a full recovery, but people die because we're unable to properly care for patients the way we want to care for them. And so it's not just the COVID death toll, which is obviously significant, but it's all the non-COVID deaths that are happening because our healthcare system is being gummed up by preparing for or dealing with COVID right now.
Dr. Marsh, anything to add to that?
No, and I think that the social isolation is the important thing to protect, so that we don't have a continued onslaught of diagnosis. Because, like Andrew was saying, a lot of the people who are being infected by asymptomatic people. And I would just say follow the recommendations of your state and city health departments with the recommendations for testing should you become symptomatic and think that you have COVID. Mm-hmm. And check in on your neighbors, check in on loved ones, especially those who are elderly, those who are highest risk. Call up, see if they need anything. These are small things that we can do, especially when people are socially isolated. They tend to get more lonely, and I think you'll have some more mental health issues. And this is an opportunity for us to help those in our community. So, I think it's important to stay in contact by phone with our friends and families.
Let me ask you guys both this, because hopefully I'm sure you guys don't have a lot of time to do this, but I'll just scroll Facebook and it'll make me insane with all of the misinformation that's out there. Are there bits of misinformation you've heard or are hearing that you want to correct? Or, the thing I continue to hear from people is, why weren't we doing this with the seasonal flu? Why didn't we have a reaction with this to H1N1? I don't necessarily have the answers to that, because I think they look at the death tolls or the total cases and they look very similar. And so they don't understand why we're doing it here, and then they don't take the advice that you guys are to take seriously. How would you, Dr. Sauer, how would you answer that?
Yeah, so H1N1 was bad, but the total death toll didn't end up being, as much as people were expecting at the time. I remember being in Boston when H1N1 happened, and what was scary about that is people my age at the time were dying very aggressive forms of significant illness in the ICU and requiring things like ECMO, which you've heard about. But that was the flu. This is a different virus. And I was doing a podcast last week on parallax, and I acknowledge, and I'll acknowledge here, that early on, many of us, including me, said, why are we making such a big deal out of this? The flu kills 30,000 people. I just got to be honest, that's ignorance. All right. I was ignorant, and I got much more educated on this over the last several weeks, and this is a different thing. So now we went from 1,000 deaths over the course of a month, and then over 2 days, another 1,000 deaths. And now that we're at 3,000 deaths, these projections that you're hearing about, especially if people do not get the message on how to shut down community spread, those death counts that you're hearing, the projections of 80, 100,000, 120,000 are looking very, very real. And so we already know, if those are right, that this is worse than any seasonal flu we've ever seen. And again, learn the lessons of history. In 1918, we had a flu pandemic. It was a different flu. It had a genetic shift. It was a different flu than the world had ever seen. It killed more people than the people dying in World War I at the time. And the story that people need to know is the difference between Philadelphia and St. Louis at that time. Philadelphia ignored social distancing, had a giant parade, and had significantly more deaths at that time than St. Louis when they figured out to take it seriously. We don't need to reinvent the wheel here. This is a different virus. It's behaving differently. It's not the flu. It will absolutely kill more people worldwide than the flu, particularly if we don't make some changes. And if all of us physicians and scientists across the country are just a bunch of crazy people, we'd be happy to be accused of being crazy in 6 months if it turns out we're wrong. But that means people didn't die. But if it turns out that we don't listen to the experts and don't listen to our leaders, and people do die, this will affect everybody. And we've seen lots of cases of young people saying, I don't really care, having COVID parties. And then those same people have loved ones that end up in our ER, end up in our ICU. And so it doesn't really matter whether you believe this virus is going to impact your life. It will, whether you believe it or not. And the biggest message I can say is stop spinning this as a hoax. We obviously want to get the economy back, but the best way to get the economy back and get people back to work is to stop the virus. And that's what we need help with on the front line. We don't need to shut down forever. We need to be able to get caught up with our staffing, our ventilators, our PPEs, make sure our surge capacity is appropriate, make sure we can get a vaccine trial going, which has started, make sure we have therapies. And once we have those things, we can all get back to life. We have some deaths we can prevent, some we can't. But this is about trying to reduce the amount of casualties.
Dr. Marsh, misconceptions that you're hearing.
I think Andrew got all of them right there. I think it will affect everybody who's listening. I think everybody's going to know someone who will ultimately be hospitalized and hopefully not know somebody who was will expire because of this infection. But this is affecting a lot of people. And I think that we need to change our behavior for some time. It's our responsibility as citizens of the country and as of our community. And I think that we can't get lackadaisical as we see infections start to plateau and slow down. We need to remain vigilant so that we can continue to be thoughtful about how we reopen up so that we can control the spread from getting out of hand again.
I know we only have a few more minutes, but and I know you guys aren't necessarily the ones who are going to be delving into numbers to look at this thing out into the future and those sorts of things. But I think a lot of people are just like, okay, but we got to know that it's going to end at some point. Do we have, because, is it going to be a year? Is it going to be months? Is it going to be weeks? And I know you don't know the exact answer to that, but what can you tell people when they ask?
We know there's reasons to be hopeful. So we aren't just trying to spread fear and fear mongering. So, for example, we know that the Southern Hemisphere is not being hit as hard as the Northern Hemisphere. So there's a lot of reason and science behind the argument that as the weather changes and becomes more hot and humid, we will see a slowing. Also compounding the efforts of social distancing. As we get through everybody's peak and everybody's surge, we know that we should have a period of respite and the cases won't stop, but they'll be low enough that the healthcare system should be able to handle those and help reduce the unavoidable deaths. And again, the casualties are not just about COVID, it's about all the strokes and traumas and heart attacks out there that we can't take care of well because of COVID. So we need to be able to get back to the work of taking care of sick patients. There'll probably be another bump. If you look at 1918, there's always a second bump. So people should be prepared for that. This is the first wave. There'll be another wave. But again, it shouldn't be as big as the first wave. History has proven that. And, if you look at 1918 flu, it was all over in about 18 months. So we've got this wave now. Many people believe that we will start seeing some reasonable activity rev back up in, late May, early June. It doesn't mean we can't do anything till those periods, but there may be some relaxing in some areas. And some areas may not get hit as hard because we do the right things. I would love for Kansas City to be a city, and also for Lincoln and Omaha, for those to be cities that can be proud in 6 months and say, we listened, we took the advice, we took the lessons from New York, and we changed. And because of that, our curve was blunted. That's success. And so it may not be as bad for Kansas City or Lincoln. But we haven't seen enough data to say that for sure. So I think you're looking at a few different waves, but as vaccines come out, as treatments come out, as ventilators are up online, as we have better testing to trace patients, these things will help reduce the need for society to shut down and we can get back to work.
Dr. Marsh, same thing for you. What kind of timeline do you think we're looking at here?
I think the timeline is really going to depend on how we act today. And if we take the personal responsibility to act today, we can affect tomorrow. But I think we're looking at months of change.
Dr. Marsh, I'll finish with you on this. Number one, thank you both for doing this, but even for more than that, doing what you're doing. I can't imagine what the day life is, not only for you, but for other nurses, for staff, for everyone associated with that. So I don't mean it to be kind of this trite thing, this cliched thing, but I'm super thankful that there are people who want to do this in this world. because I don't think I would, to be honest. And maybe you wouldn't want to do my job either, though. Dr. Marsh, finish on this. Just give me an idea. What's going through your head all this time? I mean, beyond all the social distancing and the advice that I said, what can people do to help? They say they want to express their thanks to you guys and the people you work with. What's the best way to even do that at this point?
You know, I think first and foremost is just do their part about staying home. You know, if they know someone who is a healthcare worker, whether that's a nurse, a physician, you know, find some time to thank them for what they're doing. And I think that goes a long way. But a lot of it has, you know, like I said before, is small acts of thoughtfulness can go a long way. So reaching out to those who are high risk and making sure they're okay, making sure they have access to the food and water that they need to be safe, so they're not out there venturing out getting sick. You know, I think those are good ways, easy ways to start.
Dr. Sauer, same question for you.
Yeah, those are the right things. Stay home. That's the most important thing you can do to help your healthcare teams, is stay home if you don't need to be out. And then I think that it's just looking for ways to help your neighborhood. So, you know, checking on the elderly lady that lives down the road and you know, maybe stepping in front of her driveway and you know, trying to find a way to communicate in social distancing to interact. There's a lot of people out there helping to go do the grocery shopping for these elderly vulnerable populations so that they don't have to go out and be exposed to the grocery store. And there's a lot of young people that could help do those things. I think, you know, supporting your local business. So, for example, we try to do a lot of takeout in our neighborhood to support our local businesses because they can drop off food at the curb, or you can pick it up and minimize exposure. And that, again, helps support your local economy. You know, businesses need our help. And so we got to keep things going and just trying to encourage people and checking in. Because I think people can get very depressed. The mental illness epidemic that's going inside with this is not trivial. And so checking in, saying thank you, your healthcare workers, especially in places like New Orleans and New York City, honestly, they're being traumatized. They're like soldiers being sent to war without seeing the enemy, without helmets, without ammo. And it's just like any war. And we shouldn't diminish that for our healthcare workers who are on the front line, particularly where it's really heavy, like New York City and New Orleans. And we should say thank you, and we should encourage them and check in with them and say thank you for what you're doing, because this takes a lot of courage every day to walk into a unit where you can't even see your enemy. It's invisible, and especially when you start seeing your friends get sick and die. And that's happening. And we have to take this seriously and just be encouraging and hopeful to people.
What's one thing you guys can't wait to do when this is all over and we can not be socially distanced again?
I look forward to having a beer next to somebody, not having to do it over a Zoom.
That sounds good. How about we all get back together? Sometime we'll all get back here together, maybe on a football Saturday, and we'll actually do that in person sometime. Sound good?
That sounds great.
Sounds great. Thank you.
Yeah. Doctors, I want to thank you for your time. So proud that that this area, that this state has produced guys like you who are doing what you're doing in different parts of the country on the front lines of this. I really thank you for giving me this time. We're going to spread it wide, and hopefully a lot of people are going to hear it. We'll play some of it on the radio. This will be viewable on YouTube. I'll put out links for that if people want to rewatch later. I know we've had a handful of people viewing live as well, and maybe we can do it again, but our thoughts are with you. Thanks again, guys, and be safe out there, all right?
Take care of yourselves.
All right.